Assalamu alaikum wa rahmatullahi wa barakatuh. I'd like to welcome our audience in our second annual Arab Thyroid meeting. And yesterday was really a great pleasure where we had excellent talks with top-notch speaker. And I would like to thank our audience for their interaction. And I would hope that they will continue this interest in this day as well. I would advise our audience to visit the virtual booth, and also I will call the audience for their feedback and suggestion to improve our program for next year, inshallah. We'll start with the state-of-the-art lecture, and the speaker will be Dr. Kristien Boelaert. She's a professor of endocrinology at University of Birmingham, UK, and she will present to us the year in the thyroid.
I would like to thank the organizers for asking me to present the year in thyroid. My name is Kristien Boelaert. I'm a professor of endocrinology from the University of Birmingham in the United Kingdom. These are my conflicts of interest. So I was asked to present the year in the thyroid. Now, when you put in thyroid in PubMed and limit it to the last year, there were 11,170 publications. I've, of course, read them all, but what I have tried to do for this presentation is give a summary in the fields of hypo and hyperthyroidism, also looking at mild thyroid dysfunction, effects of thyroid and pregnancy, thyroid nodules, and thyroid cancer. So this talk is really split into 6 parts. Starting off with hypothyroidism then. So there have been a number of studies published looking at thyroid hormone replacement in a hospital setting, particularly looking at outcomes, but also how we predict levothyroxine dose selection in patients who've undergone thyroidectomy. Finally, there's been a further study looking at liothyronine replacement in patients undergoing cardiac surgery. Looking then at the symptoms of hypothyroidism, there's been an interesting paper on how patients interpret brain fog. And then inevitably, we have to talk about treatment of hypothyroidism with non-levothyroxine treatments. And I have a few papers to present on this. So suboptimal thyroid hormone replacement in patients admitted to hospital is associated with adverse outcomes. So this was a large retrospective cohort study. You can see more than 43,000 patients who had been admitted to hospital, of whom 8,800 had hypothyroidism. All patients were aged 64 or less. And then patients were divided according to their TSH in subgroups. And you can see that patients who had a normal serum TSH had the best outcomes. So they had the shortest or the lowest rate of 90-day readmission, and also had the lowest in-hospital mortality rate. In patients who had a very high serum TSH, so greater than 10 millunits per liter, you can see that the rates of readmission were significantly higher. So it's really important in patients who have significant hypothyroidism that we replace them in hospital. So generally, we do a weight-based prediction in patients following thyroidectomy to determine what dose of levothyroxine they should take. So this here was a study that looked at 951 patients who had undergone thyroidectomy, and a number of machine learning methods were evaluated, of whom only 30% of patients were on an accurate levothyroxine replacement. So less than half the patients discharged from hospital on levothyroxine have an accurate dose. You can see here that the within target reference range for all patients was only present in about 30%, and it was particularly obese patients who appeared to be very over-replaced with levothyroxine because they all were discharged with within a below target TSH range. So what these authors here did was, based on this wealth of data, develop a web-based dose calculator, and you can see this is the website here for it. So if you have a patient in hospital where you need to predict the dose of levothyroxine that you should go home on, so what this takes into account is the gender, the patient's age and height, whether they're pregnant or not, whether they're taking calcium supplements, and then what the target range of TSH is. And again, this is really important because not everyone has the same target range. If you fill all these things in, like I did here, then you will get a calculated dose requirement. So this may be useful for you in your day-to-day practice. So we all know that in patients who undergo cardiac surgery, the finding of a low circulating T3 is associated with worse outcomes, as it is with many patients on intensive care, a low T3 syndrome being a particular marker of sick thyroid. So what this systematic review here was looked at 34 studies, more than 2,500 participants, all of whom were receiving T3 replacement following cardiac surgery, so various forms of cardiac surgery. So what was found in adults was that the T3 replacement resulted in improved cardiac index, and this was without any detrimental effects on the heart rate of the patients, the risk of in-hospital atrial fibrillation or mortality. So this was a safe way of doing it with a positive result in cardiac index. This was, however, not found in children. Moving on then to symptoms of hypothyroidism. And we know that brain fog is a very commonly reported symptom, especially in those patients who don't feel well on their levothyroxine replacement. So this was an online survey study between September and October 2020 of 5,000 patients with hypothyroidism who reported brain fog. The mean age of patients were 50 years, the vast majority were female, and nearly half of them had Hashimoto. You can see that brain fog was present in nearly 50% of them prior to diagnosis, and then the vast majority of them reported brain fog frequently or all the time. The symptoms associated with brain fog were mostly fatigue and forgetfulness, and it was found that increased rest most commonly provided improvement in all of these symptoms. Moving on then to non-levothyroxine-based treatments of hypothyroidism. So this is for the 10 to 15% of patients who don't feel well on levothyroxine. And indeed, there have been a number of systematic reviews in recent years, but this is the most up-to-date one, which encompasses the most studies. So this is a systematic review of 18 studies encompassing 883 patients. I could put a lot of these forest plots here, but I've only put it for depression and fatigue. But essentially, when you do the systematic review and meta-analysis, there is no difference in patients receiving combination therapy versus levothyroxine monotherapy in regards to depression, fatigue, pain, anxiety, and anger. However, when it was looked at which treatment patients preferred, there was combination therapy was preferred slightly by patients who received this versus patients receiving levothyroxine monotherapy. So there may be a preference, but no clear clinical benefit. And then a very important study that has come out over the last year looks at potential risks of liothyronine replacement. So this was a multi-center hospital database study looking at nearly 4,000 patients treated with levothyroxine and 1,500 treated with liothyronine. Some of these patients were treated with liothyronine for a very long period of time. And you can see that there was a significantly increased risk of heart failure and stroke in those patients treated with liothyronine, particularly in those who were taking it for a very, very long period of time. So I think this is very important and clear evidence that giving liothyronine treatment may not necessarily be that good for long-term health outcomes. And of course, one of the problems we have with liothyronine is that they're very short-acting preparations. So there are now a number of compounds under development looking at longer-acting T3. So this is a very nice study published in Thyroid in 2022, where there was a complex of zinc and T3 with the proviso that this adheres to the intestinal mucosal lining much better and therefore provides a depot of slower release T3. So this was 12 healthy volunteers in a crossover design. So patients received placebo, liothyronine, and then the short-acting liothyronine and the long-acting liothyronine, and there were 2-week washout periods between them. And what this very much looked at was the pharmacodynamic effects. And you can see, so the black dots here is what happens in the complex treatment, the long-acting treatment. You can see that there is very much less of a peak and that the plateau stays much longer. So there is some promise here that a longer-acting T3 combination may actually come in use, and this may actually significantly benefit patients. So to conclude the first part, studies have shown that high serum TSH is associated with increased mortality and longer hospital stay. We have a new web-based calculator to calculate the dose of T4 that patients need to be sent home on following surgery. An improved cardiac index following T3 in patients undergoing cardiac surgery. We have newer data on how patients perceive brain fog, and further confirmation that there are no improved clinical outcomes when patients are given combination therapy with T3 and T4. There is also a further warning that long-term T3 replacement may result in adverse cardiovascular risk, and a number of novel T3 compounds are in development. Moving on to the second part of the talk then, this looks at hyperthyroidism. So there have been a number of studies looking at Graves' hyperthyroidism. So Rituximab use in young children, quality of life, as well as the occurrence of Graves following SARS-CoV vaccination. A number of studies looking at thyroid eye disease, a prediction model, as well as an immunological treatment trial, and then looking at some new therapies that are on the horizon for Graves' disease. So this is a study that was conducted in the United Kingdom, looking at young people, so aged between 12 and 20 years, with Graves' disease. As you are aware, these patients particularly respond very poorly to anti-thyroid drugs, and generally remission rates or long-term remission rates are in the order of about 25%. So all these patients received a dose of Rituximab at diagnosis and then underwent treatment with anti-thyroid drugs for 12 months. Anti-thyroid drugs were then stopped and they were followed up for a further 12 months. After 24 months, half of the patients remained in remission, so this is better than general outcomes, and you can see how there was a very positive effect on the levels of TSH receptor antibodies following this administration of Rituximab. So there is hope on the horizon that remission rates may actually be improved by administering this immunological treatment at the start. There has been a study that has looked at patient-reported outcome measures. So this is quality of life in patients undergoing thyroid surgery. So this was 85 patients with Graves' disease treated with surgery, an unblinded study. And unfortunately, the indication for thyroidectomy was not entirely clear. But you can see that patients short-term following thyroidectomy felt significantly better than before thyroidectomy. I would, however, warn that we need to be careful with the interpretation of this data, since there is no long-term follow-up available. And like I said, the indication for thyroidectomy was not entirely clear. But maybe doing a thyroidectomy in patients with Graves' disease is not so bad for their quality of life. So we all know that Graves' disease, in part, the pathogenesis is determined by viruses, and it's certainly been anecdotally described that patients following COVID vaccination develop new onset Graves' disease. So this was 12 patients who either had worsened or new onset Graves' disease. The majority were female with an average age of 35.5 years. So the immediate onset following mRNA vaccination of Graves' disease was 17 days, and this occurred both after a first or second dose. But you can see that for the majority of these patients, actually free T4 normalized within 42 days. So this was a transient effect, and a number of other cases have been described in the literature. The mechanism through which we think this occurs, so we know that there is direct activation by the virus of ACE2 receptors. It's likely that there is cross-reactivity between the vaccination and thyroid antigens. It may be that certain people with a genetic predisposition are more likely to develop this, or that in vaccine adjuvants, further autoimmunity is induced. So moving on then to Graves' ophthalmopathy. So this is a predictor model of Graves' ophthalmopathy in patients presenting with new Graves' disease. So this was 1,074 patients who were newly presented, of whom 101 developed Graves' ophthalmopathy. So this study indicated a number of factors that independently predicted the development of Graves' ophthalmopathy. So it was more common in females, unsurprisingly in smokers, in people who have a positive family history. And based on these data, the authors then developed a nomogram which can help counsel and make treatment decisions. So this is important when we make treatment decisions for patients with Graves' disease, because obviously we would not like to give radioactive iodine to someone who is likely to predict to develop Graves' ophthalmopathy. So we have a probability of Graves' ophthalmopathy here based on these factors that are calculated into the nomogram. And then in 2021, we had the OPTIC trial looking at teprotumumab for Graves' ophthalmopathy, which was a phase 3 double-masked RCT. We have then a further follow-up study published in 2022, the OPTIC X trial. So these are patients who previously were either allocated to the placebo group in the original OPTIC trial, or who had persistent proptosis or disease flare-up in the TEPRO original trial, so 37 patients. And you can see here, so the gray line are those patients who went from placebo to the OPTIC X, so the TEPRO trial, and the blue line is from the original trial. And you can see that following 8 infusions over 24 weeks, proptosis improved significantly, as did diplopia, as did the clinical activity score. So this indicates that even in patients who have a longer duration of thyroid eye disease, 12.9 months on average here, compared with 6.3 months in the original OPTIC trial, that there is hope that this treatment, which of course is very expensive, results in better outcomes. And then a number of novel immunomodulatory treatments for Graves' disease have been developed. So one that's now been evaluated in a number of studies is the K170, which is a TSH receptor monoclonal antibody. So this was a study looking at 18 patients who had stable Graves' disease and were established on anti-thyroid drugs. What this graph here illustrates are the pharmacodynamic effects that happen following administration of K170. So you can see a significant improvement in TSH with a significant reduction in circulating thyroid hormones, resulting in a stopping of anti-thyroid drugs and in a number of patients the need to start levothyroxine. So not only did this trial indicate pharmacodynamic positive effects, but also clinically significant improvements of Graves' disease, such as reduced tremor, improved focus and sleep, as well as improvements in Graves' ophthalmopathy. So to summarize the second part, rituximab may have beneficial effects on remission rates in young patients with Graves' disease. Maybe thyroid surgery results in better quality of life in patients with Graves' disease, but like I said, those data have to be taken with a pinch of salt. New onset and flare of Graves' disease has been described following COVID vaccination. We now have a nice prediction model of Graves' ophthalmopathy in patients presenting with new Graves' disease. TEPRO is beneficial not only in patients who have a short duration of thyroid eye disease, and the therapeutic potential of TSH receptor blockade has also been illustrated. Moving on then to consequences of mild thyroid dysfunction. So I have 3 studies to highlight here. One that emphasizes the need for appropriate reference ranges to diagnose thyroid dysfunction. One that looks at cardiovascular disease, particularly in patients with type 2 diabetes and mild thyroid dysfunction, and one that looks at depression in young people. So we all know that TSH reference ranges change and that there is a shift in TSH with age. So this is a large study from Japan. You can see here a large number of TSH measurements on various assays. What's shown on the left is if you use the manufacturer's reference range, and then the different thyroid dysfunction conditions that you can get. So this is for women at the top and for men at the bottom. And you can see that there is quite a high prevalence of subclinical hypothyroidism, particularly in older age groups, but in old age groups when you use the manufacturer reference ranges. However, when you use age and sex-specific reference ranges, these prevalences are significantly lower. A further thing to note is that there are very many fewer patients with subclinical hyperthyroidism when using the manufacturer's reference range compared with age and sex-specific reference ranges. So it's likely that unless you use these specific reference ranges, you overestimate the amount of subclinical hypothyroidism and you underestimate the amount of subclinical hyperthyroidism. particularly in middle-aged individuals. So the Fremantle Diabetes Study Phase 2 looked at patients with diabetes. So this was 1,250 patients with type 2 diabetes. The mean age was 65 years and 56% were male with an average diabetes duration of 8 years. 61 of them developed subclinical hypothyroidism, and this was significant or raised over 10 millunits per liter in 4 of them. Well, this study found that there was no increased risk in all-cause or cardiovascular mortality in patients with diabetes who developed subclinical hypothyroidism. And what this on the right here indicates is the analysis looking at independent predictors of stroke and myocardial infarction. And you can see that this was independent of the TSH category. So it appears that the addition of mild thyroid dysfunction or subclinical hypothyroidism in these patients with diabetes is not an independent driver of their increased cardiovascular risk. And then the final study in this section looks at the development of depression. So in 2021, there was a number of nice studies linking major depressive episode in adults to subclinical hypothyroidism. So this is a part of a very large survey performed in Germany, the German Health Interview and Examination Survey, particularly looking at children and adolescents. So more than 4,000 adolescents were followed over a mean period of 6 years, of whom 121 developed a major depressive episode. There was no association between the presence of subclinical hypothyroidism, which was present in 111 versus 4,000 patients with who were euthyroid. And this is thought to be representative of a very large proportion of the general pediatric population. And you can see here at the bottom that even when you looked at the quartiles of TSH and free T4, there was no significant link to major depressive episodes. So whilst in adults there may be a link there, it does not appear that this is the case in children. So what this section has illustrated that it is really important to use age and sex-specific reference ranges for accurate diagnosis of mild thyroid dysfunction, but that subclinical hypothyroidism is not an independent predictor of cardiovascular disease in patients with diabetes. There was no link between subclinical hypothyroidism and major depressive disorder in young people. Moving on then to pregnancy. So there has been a further trial looking at the treatment of TPO antibody positive women and pregnancy loss with levothyroxine. A further follow-up study from the tablet trial looking at progression to hypothyroidism, the importance of preconception TSH on obstetric outcomes, and then links between thyroid function and preeclampsia, as well as what happens to reference ranges during pregnancy. So we've now had a third trial looking at treatment with levothyroxine of patients who are TPO antibody positive but have normal thyroid function. This was the T4Life trial, which recruited 187 women. The primary outcome was live birth beyond 24 weeks. So people were randomized to receive either placebo or levothyroxine. And you can see that there was no difference in the primary outcome. So when you look at the cumulative conception, this was no difference between the two arms. So the treatment with levothyroxine was given at a dose of 0.5 to 1 microgram per kilogram. And based on the 3 trials we have now had, the routine use of levothyroxine cannot be recommended in TPO antibody positive women who have biochemical euthyroidism. So I was part of the tablet trial that was published in 2019. And what we did in a follow-up study was look at those 940 women who we recruited to see which of those women, because of course they all had positive antibodies and normal thyroid function, we wanted to see how many of them developed subclinical or overt hypothyroidism. And so this was found in 7.4% of patients. It was higher in those patients who were on placebo compared with the levothyroxine group, with a significant risk increase. The vast majority of the thyroid dysfunction emerged pre-pregnancy. It was more prevalent in patients who had a higher median TSH concentration and higher TPO antibody titers. And those patients who had treated either subclinical or overt hypothyroidism had a higher failure to conceive rate compared with euthyroid women with an adjusted risk ratio of 2.02. But looking at the live birth rate, this was not different between the groups. And I think what this study illustrates here that yes, indeed, those patients who have positive TPO antibodies are more likely to develop thyroid dysfunction. And therefore, whilst we cannot endorse levothyroxine treatment to result in better outcomes, regular monitoring of thyroid function tests is very much valid in this group. This is a very nice study from China looking at an extremely large cohort. You can see more than 11 million women who are trying to become pregnant. It was a population-based cohort, and they were studied between 2013 and 2016. You can see 42% of women became pregnant within 1 year. And what's important to look at here is the effects of TSH. So the top part here is the fecundability, and you can see this U-shaped curve. So the best outcomes are with a serum TSH that's within the normal range, and worse outcomes are found with low and high serum TSH. Similarly, looking at spontaneous abortion rate, again, we have this U-shaped curve here with worse outcomes in patients who have TSH that's significantly below or above normal. So the median TSH of this woman was 1.73. And what this study concludes is that abnormally high and low preconception TSH is associated with worse outcomes with regards to conception. So this is a study from Tim Korova and his thyroid in pregnancy consortium, this time looking at development of gestational hypertension and preeclampsia. So it's an individual patient data meta-analysis of nearly 40,000 women from 33 different cohorts. So what the study found was that preeclampsia is independently linked to subclinical hypothyroidism. But importantly, what was found is this U-shaped relationship of TSH with preeclampsia. So again, very low and very high TSH scores are independently associated with development of preeclampsia. And that is something very important to bear in mind. And then again, a study from the CASE consortium where, of course, if you have 33 different cohorts, all of them will have slightly different assays that have been used. So what they studied was the effect of the assay on TSH and free T4 concentrations. So you can see here in this graph, and I know it's quite busy, but what it shows is widely differing absolute values for TSH and free T4 reference intervals. And therefore considerable heterogeneity when they are calculated. So they also looked at a number of factors that affect TSH measurements, and the presence of TPO antibody positivity is definitely associated with an increase in the upper limit of TSH, but less so for the free T4 reference intervals. And there were no additional reference population criteria such as smoking history, obesity, hypertension, presence of diabetes that affected the TSH reference ranges. So very much the recommendation that ideally you should use pregnancy-specific reference ranges determined in a patient group without TPO antibodies who are iodine sufficient is important. And I think the further thing to conclude from this is that's really important that you know which assay you are using to determine thyroid function during pregnancy. So to summarize the fourth part of the talk, studies have shown that there is no benefit of levothyroxine in TPO antibody positive women with normal thyroid function. This is the third trial to confirm this. Based on data of progression during the tablet trial, women who have TPO antibody positivity are more likely to develop hypothyroidism, and therefore regular monitoring is important. Abnormally high and low TSH concentrations are associated with poor fertility outcomes, and subclinical hypothyroidism is associated with an increased risk of preeclampsia. Moving on then to thyroid nodules. I have 4 studies that I would like to illustrate here. One that looks at molecular predictors of malignancy in thyroid nodules. One that has looked at ablative techniques for thyroid nodules and radiofrequency ablation, and then also radiofrequency ablation in papillary thyroid microcarcinomas. So this is a nice study that was published in Thyroid in 2022. So this was looking at 2 different molecular predictor tools, the Afirma gene classifier and the ThyroSeq classifier, looking at 343 patients. You can see this was a total of 375 indeterminate nodules. So all patients had an indeterminate nodule that underwent ultrasound and then either a FIRMA or a ThyroSeq test. So what was found that in nodules that were sonographically low or intermediate risk, the use of both a FIRMA and ThyroSeq resulted in a significant improved prediction. So you can see that the predictor rate here went from risk of malignancy of 21%. If this was positive on a FIRMA, this resulted in rate of malignancy of 56% with a positive likelihood ratio of 4.8. Very similar results for the ThyroSeq, this went from ultrasound risk of 24% of malignancy to 34%, and again, a very significant increased likelihood risk ratio. Similar, if these tests were negative, again, this was a very good predictor. However, in patients who have high suspicion nodules, the same findings were not evident. And indeed, this was less useful in those situations. So these tests have limited diagnostic values in high suspicion nodules, but both assays perform very well in ruling out malignancy in low or intermediate suspicion nodules. So as we are all aware, there are now a number of ablative techniques for thyroid nodules on the market. A systematic review has been undertaken of ethanol ablation, microwave, laser, radiofrequency ablation, and high-intensity ultrasound, with a total of 690 articles published. It was indicated that these methods are suitable as a first line for benign nodules with compressive symptoms, as well as for papillary thyroid microcarcinoma and recurrent papillary thyroid cancer. It was found that these methods are less efficacious for autonomous nodules, but still safe. However, it is more likely if you treat an autonomous nodule with a thermal ablation technique that a retreatment may be needed. But what is very much emphasized by this review is that advanced training and proficiency is absolutely essential for good outcomes. So one of the most prominent thermal ablation techniques is radiofrequency ablation, which of course is used very widely in Korea, in the United States, and in certain countries such as European countries such as Italy. So this was a multi-center study from the United States looking at 223 nodules, and you can see how radiofrequency ablation resulted in very significant volume reduction, mainly during the first month following treatment. And when looking at procedural complications, these were actually very, very limited. And out of the 223, only 6 patients developed a complication, and they tended to be temporary rather than permanent. Thyroid function was remained in all patients. So of course, when considering either Hemi thyroidectomy or radiofrequency ablation, this is a very important factor for most patients. And then this has not only been shown to be useful in benign nodules, but also in papillary thyroid microcarcinoma. And this is a systematic review of 15 studies. You can see more than 1,700 patients and a large number of tumors, patients with age between 42 and 66, and they were followed up for a mean of 33 months. You can see that the pooled disappearance rate was 79%, and tumor progression rate was 1.5%. That's illustrated by these forest plots here. So this is a very effective treatment to make papillary thyroid microcarcinomas disappear with a very low risk of tumors actually progressing. Again, there were only very few complications. 3 major complications were reported, 2 voice changes and 1 arrhythmia. But it is deemed that this is a safe and efficient method for treating papillary thyroid microcarcinomas. So to summarize the section on thyroid nodules, molecular testing has been shown to perform well in ruling out malignancy, both the FIRMA and the ThyroSeq platforms, particularly in low to intermediate risk nodules, but not in high risk nodules. We have had a consensus statement on novel ablation techniques for thyroid nodules, and this has been shown to be mainly radiofrequency ablation has been shown to be effective and safe, both in managing benign thyroid nodules, but also in papillary thyroid microcarcinomas. And you can see that my pie chart is nearly full here because we're now moving on to the final section, which looks at thyroid cancer. So a study looking at thyroid autoimmunity and the risk of papillary thyroid cancer, treating relatively low risk differentiated thyroid cancer with lobectomy versus total thyroidectomy, active surveillance of low risk thyroid cancer, the value of serum thyroglobulin when not giving radioactive iodine after lobectomy, and then radioiodine ablation in low risk thyroid cancer. So I think we're all aware that thyroid cancer is more likely when thyroid autoimmunity is present. This was a nested control study. You can see over a long period of time, 1996 to 2014, where 451 patients were diagnosed with new papillary thyroid cancer. So they all had their thyroid antibody measured 3 to 5 years pre-diagnosis and 7 to 10 years pre-diagnosis. And you can see that long-standing thyroid immunity was associated with an increased risk of developing papillary thyroid cancer. And there seemed to be a dose-response effect in that higher levels of antibodies were associated with a higher risk of developing thyroid cancer. What the authors, however, warn against is that routine cancer screening in patients with positive antibodies, which of course we find in about 15% of the population, may overdiagnose the presence of papillary thyroid carcinomas. Looking then at how to treat patients with thyroid cancer. So this here is a long-term follow-up study of patients who either underwent lobectomy, so 943 patients underwent lobectomy versus 2,800 patients who underwent total thyroidectomy. You can see here a long period of follow-up. So patients did not have lymph node involvement, but this did not just include microcarcinomas, but also T2 tumors, so tumors up to 4 centimeters. It was a retrospective study with propensity score matching, and there was no difference in overall survival, disease-specific survival, and recurrence-free survival. So indicating that a thyroid lobectomy in those patients with tumors up to 4 centimeters without lymph node involvement results in similar survival outcomes. So low to intermediate risk differentiated thyroid cancer may well be treated with lobectomy rather than with a total thyroidectomy. So what I'm now going to present is 2 studies that have formed the basis of the American Thyroid Association guidelines on thyroid cancer, which will be published hopefully by the end of this year. So this is 18 studies that were included in a meta-analysis, looking at nearly 6,000 patients who underwent active surveillance for differentiated thyroid cancer versus surgery. Most data were limited to very small papillary thyroid cancer, so those microcarcinomas, and the mean follow-up was 2.7 years. It appears from this study that active surveillance is similar to surgery for low-risk small papillary thyroid cancer in terms of mortality, risk of recurrence, and other outcomes. It has, however, been commented that data were very heterogeneous and there were a number of methodological limitations. Confounding factors were difficult to take into account, and what this study very much emphasizes is that there is further research needed for, certainly for non-papillary differentiated thyroid cancers, those greater than 1 centimeter and in older patients. But it looks like active surveillance may well be a good alternative to surgery, certainly for small tumors. Looking then at use of thyroglobulin in various scenarios, various patients that we get. So this was 37 included studies, looking at nearly 9,000 patients. A small group had partial thyroidectomy. 751 had a total thyroidectomy, but were not planned to have radioiodine. And then the majority had a measurement before they underwent radioactive iodine. What the meta-analysis concludes is that after lobectomy, thyroglobulin measurements are not accurate. So it's not recommended if a patient has just had a lobectomy for a low-risk thyroid cancer, that thyroglobulin measurements are used to look at recurrence or progression of disease. After total thyroidectomy without radioactive iodine, it was concluded that thyroglobulin is generally low and stable, and therefore certainly serial measurements of thyroglobulin may be useful here. After total thyroidectomy, where radioactive iodine is planned, a maximum of 2.5 nanograms per mil seems to be a very good cutoff for identifying those patients who will have low risk persistent or metastatic disease. So those with a maximum TG of greater than 2.5 may well be those that we need to keep a closer eye on. And then finally, this is a trial that was published in 2022 looking at administration of radioactive iodine or not in patients with low-risk thyroid cancer. These are patients with T1 and T2 tumors without nodal involvement. So what the study found was that there was no difference between the groups, so whether you gave radioiodine or not made no difference with regards to recurrence. So the non-inferiority margin was 5 percentage points, and so this was a negative trial. And then at 3 years, when you looked either at increase in thyroglobulin or the presence of structural disease in the thyroid bed, there was no difference between radioiodine or not. And so this study concluded that patients undergoing thyroidectomy for low-risk differentiated thyroid cancer, follow-up without radioactive iodine may well be the best way forward. So to conclude the final part, and you can see the pie chart is full, long-standing thyroid autoimmunity has been confirmed to be a risk factor for papillary thyroid cancer. It appears that a Hemi thyroidectomy is appropriate for low to intermediate risk differentiated thyroid cancer, and that active surveillance may well be a very effective approach, certainly in those smaller tumors. Thyroglobulin cutoffs following total thyroidectomy for differentiated thyroid cancer appear to lie around the 2.5 nanograms per mil range, and a study has confirmed that remnant ablation is not required in those patients who we are treating for low-risk differentiated cancer, certainly those with tumors up to T2. Many thanks for your attention.
Thank you, Kristien, for excellent lecture. We enjoyed the talk, and that was an extensive review of the literature in thyroid disorder. We now move to the next segment of the program with Dr. Iman Siddiqui.